All right, today we are talking about pediatrics. You guys have already started pediatrics with Dr. Nicholson, is that correct?
Yeah.
Fantastic. This is what I do when I'm not here, 1 day a week, and what I did for a period of time. I did not have a particular love for pediatrics. I just needed a job, and so I just happened to. Sometimes you find yourself in odd situations, and this is the one I found myself in. Yeah, so I started off in the ER, as you guys know, at Nemours, and so now I'm doing a little bit more work up in central pharmacy, so I'm kind of dealing with more kind of high-level work regarding kind of all aspects of the hospital, so dealing with the OR, dealing with the infusion center, dealing with, some people call it the confusion center, with the way it runs sometimes, dealing with the ER, dealing with ICU, so we get a wide swath of different sort of pediatric experience when you're working in kind of the central pharmacy area. So we'll kind of talk about that. We'll talk about what makes kids so different from a drug standpoint, because again, are they just little adults? Absolutely not. We need to treat them differently, and we'll see that when you're looking at a lot of the recommendations for how you dose things, how often you give drugs, which drugs to use, a lot of it goes back to these differences in kinetics that these kids have, right? So we'll look at things like, and some of this will be a little bit of a rehash from what we did in pharmacodynamics, but it's a good kind of refresher on the differences here, and then we'll get into specific conditions. So we'll probably talk a lot about the kinetics today, and then we'll kind of move into things like cystic fibrosis we haven't talked about before, things like NICU kiddos and how we take care of them, things like that. So we'll get more into details on those a little bit later. Okay. So anywho, what is so different with this? So we say that pediatrics is kind of a heterogeneous population. What does that mean when I say that? Very different, right? So when I'm dealing with a 1-day-old premature infant, a newborn, versus when I'm dealing with a 16-year-old, they are very different from one another, right? And so again, a lot of it goes back to knowing your audience, knowing who your patients are, and kind of making sure you're tailoring things basically to that group. They undergo constant physiologic changes, things like renal function changes drastically, hepatic function, their GI tract changes quite drastically over time. And so we're going to look mainly at that kind of transition from kind of the infant stage to kind of early adolescence. Once you get to a certain point, though, you're kind of are treating them as adults, right? So if I have like a full-grown 17-year-old patient, like you can kind of treat them as an adult. And so we'll look at when we don't have like good dosing guidelines. And again, how we normally like dose stuff for pediatrics.
Weight.
Yeah, usually weight-based, right? So we'll talk about that a little bit later. But usually you're doing weight-based. Usually it's in milligrams per kilogram. When do you kind of cap that off? When do you say like, okay? Yeah, when you start to get to the adult doses, and you'll run into that quite frequently with like adolescents. Once you start getting into the teenage years, you'll find that even like small or even large, tweens, in the 12, 13-year-old sort of age, like you can see some of them starting to get up to adult doses. And again, do you ever exceed those adult doses? Not really, right? So we really wouldn't do that for those patients. We normally would cap things out at that point. But again, when they're much younger than that, we'll see how weight-based dosing can be very useful for that. But the other thing is how easy is it to do studies, especially drug studies in kids? Very difficult, right? They're one of those protected populations, similar to like prisoners and pregnant women and the mentally disabled, things like that. They're in a protected group because they are at risk for being exploited. It's difficult to for say a 2-year-old to give consent for something, right? Because they don't really understand what's going on, and so it's very difficult to do studies in that patient population. We still do studies quite frequently. So for instance, we have a research program at Nemours where we do lots of studies for a lot of hemonc studies. So remember I mentioned the children's oncology group where we do a lot of studies for kids with cancer. We do a lot of studies with a lot of neurologic disorders. We do some GI stuff. We have some pain studies that are going on right now. So there are ways to do it. It's just much more difficult. You have to go a lot more stringent requirements for that stuff. But a lot of the data that we have, we're kind of extrapolating back from adults into pediatrics, which we know is not always going to be one-to-one based on their difference in physiology, right? So again, just take it with a grain of salt that again, when we're looking at recommendations for pediatrics, it's not going to be perfect, but we're kind of going with the best that we have. And again, a lot of drugs may not have a specific pediatric indication. However, we will still use those in pediatric patients, right? So a lot of it's off-label use, but if it's safe for an adult, then there can be some, you can reasonably assume that it may be safe for a pediatric patient should you adjust for the dose, right? Because again, anything can be a poison in the right dose, just a matter of adjusting that and make sure it's going to be appropriate for them. Let's get into some of the lingo here, just so we're kind of talking about the same thing here. So gestational age is referring to what? Basically how long they were cooking for, right? So how long they were in mom, based usually on the last menstrual period. So what's a typical kind of full-term infant? 37 like 42 is going to be kind of a full term infant. We'll talk about premature being before that, and that's important because we'll see that you know, when these kids are coming out, especially when they're kind of undercooked, as we'll say, they're premature. Like, you know, they're not functioning at the same level as a full term infant would, and you have to take that into account. So a lot of times we'll look at dosing that says like, hey, were they gestational age less than 37 weeks or greater than 37 weeks, and that will kind of delineate how often you're giving a drug or what dose you're going to be giving at. So that'll you know, kind of color a lot of how we're going to be dosing these patients. So the postnatal age is just that chronological age after they are born, and then that post-conceptional age is just a combination of the two there, right? So I mentioned preterm being less than 37 weeks, full term 37 to 42, anything post-term greater than 43 weeks. Usually don't say too many of those. Usually we induce patients by then. Now when we're talking about newborns and neonates, we're going to be referring just to that first month of age, that first kind of 28 days is when we're talking about newborns, neonates. The first year we'll call them infants, right? So again, we're specifically dealing with the NICU. We're talking about kids in that first month. Now we'll sort of keep kids for longer than that. If we have really kind of complicated NICU babies, we'll keep them in there till they're like several months old. In some cases, just because, you know, if you have a 24-weeker, which, you know, you don't really get too much younger than 24 weeks gestational age in a lot of cases, they may be in there in the NICU for, you know, months and months and months until they kind of get they're able to fly on their own essentially. But anyways, yeah, so infants are in that first year of age. So for instance, when my kid came in, my little girl Phoebe, she would be considered what? Yeah, so she's still an infant, right? Because she's 2 months old at this point, or she's almost actually almost 3 months. So she's still an infant, not necessarily a newborn, right? So even though we're doing like the newborn exam, you can kind of see she still has some of those features, but she's more developed than that. We'll call her an infant at this point. Okay, obviously toddlers being that kind of 12 to 24 age period. This gets less, the nomenclature is less important here as it is for the NICU kiddos, but you can see here, you know, young child, older child, kind of how is delineated there. And boy, those toddlers are something else, huh? I don't know if you've dealt with toddlers, but it's interesting. It's like dealing with like a bipolar, drunk person who's off their meds. It is something else. Anywho, all right, so we're going to focus on the kinetics first and kind of looking at the developmental periods here. So this is a good picture kind of showing the different components of pharmacokinetics, of drug processing in these children. And so we're going to look at one gastrointestinal function that occurs here, and you're going to notice a lot of differences that happen. So we're going to look at things like metabolism, we're going to look at gastrointestinal transit time, things like that, and how that can affect drug function. We're also going to look at things like the integumentary development, because again, we'll find that drug absorption varies pretty greatly based on transdermal absorption of across the infant skin. We'll look at that first. So again, what are the things that really inform how well a drug gets absorbed? Sort of kind of those key things we've talked about, and this goes for any drug in any patient. Solubility is good. So if a drug's not soluble, it's not going to get absorbed. Perfect. What else? The size needs to be smaller. Kind of give it away on the slide here, right? So looking at the particle size needs to typically be of a small enough nature that can be absorbed. Why does pH and pKa matter? You guys remember when we talked about that in pharmacodynamics? Absolutely, yeah. So like dissolves, right? So again, looking at changes in pH can affect drug solubility, can affect how well a drug gets absorbed. So if you put something, say like a weak base, into a very acidic solution, that doesn't really get dissolved all that well. You may have a hard time absorbing that. Or on the flip side, what we're going to see is when you have really kind of premature kiddos, their gastric acid production is not going to be great. They may have a harder time absorbing weaker acids, right? Because again, like dissolves like. Remember that when you put a weak acid into an acidic solution, it's more soluble, it's more likely to be absorbed. Remember your Henderson-Hasselbalch equation, right? Not the Hasselhoff equation, but the Hasselbalch equation, right? No Baywatch fans? Okay. Anywho, right, so we're going to see that looking at different sites of absorption, how this is going to change between, say, an adult patient versus a kiddo. So, two major things that are going to be affecting gastric absorption are going to be the gastric acidity, which we're going to see that the younger the kids are, typically it's going to be, the pH is going to be lower or higher than, say, like an adult patient. Typically it's going to be higher. We're going to see that gastric acid production is typically going to be lower. We're going to be seeing, especially like, what has that kid been swallowing when they've been in the mom for 9 months? A lot of amniotic fluid. Is that typically pretty acidic? Usually more on the neutral side of things, right? So again, that's kind of been washing down their GI tract kind of for 9 months. You're going to find that is going to be affecting pH, and especially in the very early period. So we'll look at that. But also gastric and emptying time is going to be a factor here as well. These differ pretty greatly between infants and adults, as we'll see. So looking at this pH-dependent passive diffusion, that's what we mentioned, where light dissolves light, weak acids being better dissolved in acidic solutions. Typically in preterm infants, the pH is going to be higher because they're, again, their GI tract is not fully developed. You're going to find they're not really producing as much acid as a term infant might. Typically, gastric acid production goes up with gestational age. So a kid born at 38 weeks will have better gastric acid production than a kid who's born, say, at 26 weeks, right? Usually, the pH of the GI tract is going to be around 6 to 8, and they're in the stomach for the first couple of days, and that's mainly due to that amniotic fluid that I mentioned there. As that kind of gets washed out, as that gets eliminated, then eventually the gastric acid will start to kind of kick up a little bit, and then you'll see the pH start to drop. Usually, the highest acid concentrations around 1 to 10 days post birth, so kind of give a big spurt of it, and then it starts to drop down a little bit later on during that first month of life. So. And then by 3 months, they should be pretty close to adult levels. So that is one thing that will kind of level out pretty early on in development for these kids. So as I mentioned, when you have acidic drugs, they are going to be absorbed, or less likely to be absorbed when the pH is higher versus basic drugs. They tend to have increased absorption. Okay, so that can matter for things like, for instance, if you had to give one of these kids aspirin. Aspirin's a weak acid, typically gets absorbed from the stomach. If you have a high pH, you're going to find it doesn't get absorbed all that well, right? What little kids do you think we'd be giving aspirin to? Kawasaki's is one. If you think kids with like congenital heart defects and things like that, so a lot of our cardiovascular kids, like in the cardiac critical care unit, a lot of them end up being on aspirin for the antiplatelet effects if you're worried about them clotting off inappropriately. So sometimes you'll see that. So again, we mentioned that usually don't like to use aspirin in little kids because you worry about Reye syndrome. However, there are some cases. If you see it, it does not mean it's not indicated. Okay, we'll also find that the gastrointestinal emptying time, the GIT, is going to be pretty variable depending on the age of the kid. You're going to find it's a lot slower in kids that are less than 6 months of age, and it may slow down the rate of absorption. It won't change necessarily the total amount of absorption. However, things like if they have really kind of a fast transit time and they're having like a lot of diarrhea, things like that, that may actually expel drugs before they have a chance to get absorbed. That may be one factor you run into, but you're going to find that many things can change this. So if you're looking at things like the type of feeding they have can affect this. You can find that congenital heart disease will slow, you'll have less blood flowing to the GI tract. That can slow down the transit time and lead to slower absorption of drugs. So that can be a factor here as well. Usually shorter transit times will decrease the total absorption just because it has less time to be in contact with the GI tract. You may find things like extended release formulations we don't use a lot in kids this small in infants, mainly due to the fact that they just have such a fast transit time they wouldn't have full absorption. But this may account for why you may see different levels in patients. You may find variable absorption. You may find that the same dose, even for the same size kid, if you go to their, say they had a twin brother that had some change in gastrointestinal transit time, you may find different levels there, right? So there's a lot of variability that can happen between from kid to kid. So, other things, looking at other routes of absorption for these kids. So we're looking at things like muscular blood flow, looking at mucosal permeability and skin permeability. We're going to find these are other factors that are going to be influencing how well drugs get absorbed. Obviously, muscular blood flow is going to affect what route? Intramuscular, absolutely. How about skin permeability? Transdermal. How about mucosal permeability? Maybe intranasal. More rectal. Yeah, rectal is going to be another thing. We're going to see that this is going to be a popular route. In fact, someone left me a present up here. Anyone know what this is? You can tell in the back. It's a acetaminophen suppository, unless someone's trying to tell me I'm a pain in the butt. I don't know, but probably shouldn't be touching this. Kind of gross, actually, when I think about it. But again, this comes in a very hard foil. Make sure you take the foil off beforehand. Otherwise, this will hurt. It sounds like a very common sense sort of thing, but I will tell you, a lot of lay people, common sense is not so common, right? So you need to let them know, hey, take off the foil first, otherwise we'll have like a rectal tear or something from this foil ripping them up. That's no good. Anywho, so looking at the muscular blood flow, typically pretty reduced, and we'll go over these in detail here in a little bit later in the upcoming slides, but you typically reduce in neonates. You'll find that as they get older, that will become more close to adult patterns. You find mucosal permeability, very, very efficient for little kids, and you'll find the rectal route is very much a preferred route for these kids as well. We'll see here in a minute. And skin permeability is increased. Now, skin permeability is fine, but you can actually see a lot of toxicities that come about from this, right? So we're going to find that kids' skin is typically pretty thin, underdeveloped. That can lead to some toxicity from drug absorption. I've kind of mentioned some cases, but I'll kind of reiterate them here as pertinent. So looking at intramuscular drug absorption, so it's dependent on a lot of factors. So one, you need to have blood perfusing the area of the injection in order for it to be absorbed. If you don't really have good blood flow going to the muscle, then you're not going to find that it really carries the drug very efficiently back into the systemic circulation and into wherever the drug's going to be working at. Again, you're also looking at things like penetration of the drug through the capillaries. Again, the more soluble it is, the better that absorption is going to happen there. And then we're going to look at the apparent volume in which the drug has been distributed into, right? So we're going to look at volume of distribution being very different, especially with little infants versus an adult patient, right? So basically how the neonates and infants are differing from older kids is typically going to find decreased blood flow to the muscles, because again, they're not really trying to, they don't really have a big need to perfuse those muscles as well as, say an older kid who's utilizing those muscles more effectively. You're going to find that they have a lot more water in their muscles. So this can change the apparent volume that more hydrophilic drugs are going to be diffusing into, right? So volume of distribution changes pretty greatly for infants. And basically, when you're thinking of an infant, you can kind of think of them as a big bag of water, essentially, right? They have very high water content, not a ton of fat, not a ton of muscle compared to older children. So think of them as having high water content. They're going to have a lot bigger volume of distribution. And we'll cover that again, and just to reiterate it. They're going to have a lot higher volume of distribution for hydrophilic medications than you will see in older kids. And that's going to inform some of our dosing we'll see here in just a second, right? All right, so you're going to find they also have decreased extent of muscular contractions. So again, they're not really controlling their muscles all that well. They might have some reflexes, but not really using them effectively. That will also diminish how well the drug gets absorbed from the muscle. And they also have a lot of this peripheral vasomotor instability, especially the younger the kids are. They have a hard time kind of with thermoregulation and controlling their temperature. This also kind of goes into regulating kind of their vasculature. And so you may find they have kind of erratic absorption, if anything. So intramuscular route is not great in a lot of cases for pediatric patients, or sorry, for these infants, due to these factors, due to the fact that you won't have really as consistent of an absorption as you would say from the IV route, or say potentially say the rectal route, which we'll look at in just a second here. So typically rectal absorption is going to be very good, have very vascular rectum. It's going to be able to translocate drugs very easily. It's very kind of a thin membrane, so good mucosal translocation. Probably the most common thing we give as a rectal medication for infants is probably going to be Tylenol. It's probably the most common thing we'll administer directly for those patients. There are other drugs as well, but this is the most common one. However, you have to consider, did since they had this kind of increased amplitude of rectal contractions, they could actually expel the drug out too early, and so that's one of those things you have to consider. Like, hey, you may need to redose if they, they kind of poop it out right after you put it in. So they need to make sure you're kind of having the patients or the caregivers make sure they're kind of holding it in there for a period of time, just kind of keeping their cheeks shut and allowing the drug some time to absorb. Right. Once you give the, anyone know what these suppositories usually the base is for these? Usually like cocoa butter or something like that, but it melts at body temperature basically, which is why you don't want to leave these in your car, otherwise they're going to melt and they won't really be that effective. But you allow the body temperature to kind of melt the suppository, and it can be absorbed very easily. So you need a few minutes for that to occur, right? Anywho, I should have more show and tell. I should find more stuff I can like bring in and show you guys. Pass it around. It's gently used. Just kidding. Okay. One really good route of administration we have for pediatric patients, if you need to have IV administration in a pinch, we have the intraosseous absorption, which is going to be really good. So again, how easy is it to get IVs in a small child? Difficult, right? So again, the veins are smaller. They're more likely to blow those veins. You are dealing with a child who may be squirming and may be really apprehensive about getting a shot. It can be very difficult. However, we have these big non-compressible veins essentially in their bones, and so we can use intraosseous administration. So here's kind of an old school means of getting an intraosseous needle into the bone. This is the kind of the newer ones we use in a lot of cases. It's called Easy IO, where basically it's like a little power drill that you just attach these little ends to, and based on the size of the patient, this is probably more of an adult size. This is more kind of the infant size. Attach it on there and just basically drill it in. Anyone know where the sites where you mainly use these? The tibia is a big one. Sternum can be used. The humerus, yeah, those are probably the more common ones you're going to run into. I mainly see the tibia being used probably most commonly. But yeah, basically just drill that in there, and then you can hook up your IV set and administer fluids to there. You can administer code medications, any kind of drug you want to administer can go through the intraosseous route, right? Typically, not as painful as it probably looks as using a power drill on your patient, right? But pretty, if you need it in a pinch, it's a very fast way to get an IV started, right? And again, one time I had a patient who, the little end here, the patient coded and died, unfortunately. So we were trying to remove the IO that had gotten via EMS, and this little nub here at the end, usually you kind of use that to unscrew it out of the bone, fell off, and so basically I had to like find a pair of pliers to try to like yank this thing out of. It was a bad scene. So just be aware the device can fail, but usually it's pretty good. Hopefully no one's grossed out too bad by that. But okay, so going back to percutaneous drug absorption. So again, kids' skin usually pretty thin, pretty underdeveloped, especially when you're dealing with the neonates. You can find issues where you have unwanted absorption of substances. So for instance, remember how we said iodine can not only stimulate thyroid hormone production, but can also do what? Shut it down, right? So it can actually decrease thyroid hormone production. There's a product called betadine, which contains iodine in it. It's an antiseptic. If you were to use that on an infant, they could absorb that potentially, and then have all that iodine being absorbed can cause hypothyroidism, right? So that's why you may use different types of cleaners on an infant than you would than an adult patient, right? Skin's very hydrated, so they're going to have good absorption of a lot of substances. Did I tell you about the one where the little kids were testing positive for marijuana? For THC. So there's a case, and I think it's like a California hospital, and for certain infants, they would test the urine for the child, because again, when the mom's exposed to drugs in utero, or the child's exposed to drugs in utero, that will still show positive for them shortly after birth. So you could test a kid, see if they were testing positive for anything, kind of use go back and ask the mom, like, hey, what kind of drugs were you using during pregnancy, X, Y, and Z. Anywho, so they had these babies that they were testing, they were showing it positive for THC. I doubt the kids were using the THC themselves, so you link it back to maybe it was mom that was utilizing that. And these moms were like, I've never smoked pot in my life. Like, no way that it could be possible. What had actually happened was they were using a certain, I think it was like an Aveeno moisturizer, and there was a component within that moisturizer that was being absorbed and cross-reacted with the assay that looked like THC. So the kids were testing positive. Once they switched over to a different cleanser, they were able to test it and test the kids again, and then they were negative at that point. So again, it goes back to showing you that you need to be careful with these substances. Make sure you're only using things that are approved for kids, because otherwise you can run into issues. They also have a really high body surface area to their body mass compared to adult patients. So even though they're maybe covering a relatively small amount of skin with a medication or substance, they can still have a lot of absorption. That could be a significant amount of their body mass or their body surface area. And again, one of the big things that we saw that increased absorption of drugs across the skin is what? Surface area. You cover a bigger surface area, you're going to get more drug absorption, right? It kind of makes sense based on what we know about, remember that fixed law we talked about where we're talking about drug permeability across those membranes? Bigger surface area means bigger drug absorption. So be really careful. Things like having hypoglycemia and lethargy due to isopropanol baths. Anyone know another name for isopropanol? Just rubbing alcohol, it's isopropyl alcohol, and so they were utilizing this to clean the infants, and they could actually have absorption of that. So alcohol being decently absorbed through the skin membrane, they were developing hypoglycemia related to that. And so that was one thing. Okay, we don't want to use that anymore. There's been cases where Benadryl has some topical formulations, and if you were to administer that, you have a lot of absorption of that, and then all of a sudden you have this anticholinergic kind of toxidrome these kids are exhibiting. We'll talk more about toxidromes in the tox section later on, but just be careful with that. I remember we had one kid, and I probably mentioned this story before, but this dad had chronic low back pain, and he had this custom compounded cream that he had made that had things like ketamine in it. There's amitriptyline, which, remember what amitriptyline is? Yeah, it's a TCA, so it's a TCA, which we know is good for what type of pain? Neuropathic pain. So I thought there were some neuropathic components to this, so they included that. Just a ton of different different drugs, and they're meant to deal with this guy's low back pain. I don't know how effective it was, but that's what they were using it for. And so mom was changing this infant. He was only a month or two old. We're changing the infant, and then noticed it had some diaper rash. So she went for the first cream she could find and put it on there. And you guys know about diaper rash. Like, how does that typically look? Very red, very erythematous, right? Very a lot of blood flow. So more blood flow means better absorption, right? All of a sudden you're putting on the area where the diaper is going, and then all of a sudden you're putting the diaper on, and that's doing what now to absorption? increases it even further because now you have an occlusive sort of dressing over that. So again, and it was right after bath time too, of all things. So again, the kid was hot. So again, that was increasing that kind of skin blood flow to try to dissipate some of that heat. Skin was kind of red, erythematous. It was occluded. All these things. It was just a disaster. So kid absorbed a ton of it, and then when they went look at the kid later on that night, kid was apneic, ended up getting intubated. Kid did fine in the end. But it's one of those things where they tested for levels of ketamine and actually find a decent amount of ketamine in that kid's bloodstream due to that absorption. So be very careful with transdermal drug absorption. It can definitely happen much easier than adult patients. All right. So going back to distribution, you guys remember volume of distribution? What is volume of distribution? Yeah, basically, what's the extent that a drug will partition out into the tissues, right? Because again, when we measure blood levels of a drug, we're measuring the blood, right? So again, if a drug stays all in the central circulation, that would be considered to have a lower high volume of distribution. It's all there right there in the blood. Via low volume of distribution, right? Because it's staying all right there centrally. Versus if we have a drug with the high volume of distribution, it's going to be partitioning out to the tissues. Not much of it is there to measure in the blood. Thus, you're going to have lower blood concentrations. This is going to be important because when we're trying to do therapeutic drug monitoring for some of these drugs, you need to take that into account when dosing these patients. Because remember, volume of distribution equals that dose that we administered over that initial concentration. So the lower that concentration is, because that drug's partitioned out, the bigger this value is going to be, the bigger the volume of distribution is. You guys remember that? Go back in the cobwebs, dust it off, see if you can pull it back. All those videos are still available to you. You can still go back and review them all if you like. See how we've all grown together, right? Over time. No. Again, for the big difference here is you're going to find that this can change over time. I mentioned they're big bags of water, so this is going to lead hydrophilic medications to have a much higher volume of distribution than you would see otherwise for an adult patient. So looking at distribution sites, looking at total body water, you can see how this is going to be higher as they're just born, and it's going to be dipping down as time goes on. So we're going to find fat content is going to be a lot lower when they're first born. It will perk up a little bit, but this is all going to be affecting that volume of distribution. Okay, so we're going to look at that more in detail here. So again, the factors that affect volume of distribution is going to be lipid solubility. So the more lipid soluble a drug is, the more it's going to partition out to fat tissue. You know that. How about plasma protein binding? What does that do to the volume of distribution? Decreases it, right? Why? It's bound to the serum proteins, right? So it's there in the serum. It can't partition out to the tissue because it's all stuck there, right? Tissue binding would increase volume of distribution because it's the same thing happening when those serum proteins just out in the tissue. And then peripheral tissue distribution. So we'll look at that more in detail here in just a second. So again, that kind of is kind of the culmination of that. So how far it was partitioning out is going to be affecting that volume of distribution. Yes, sir.
So if someone has a higher percentage of body fat, will they absorb the drug more than lipid soluble?
From a transdermal route?
Yeah.
So volume of distribution is more of an issue of not necessarily the absorption of the drug, but it's going to be more of an issue of how it's actually distributed. So for instance, if you have something like THC is a good example. THC is fat soluble or water soluble? Very fat soluble. So THC, and this is why when you test someone for THC in the urine, it can stick around for a long time. One of the factors that goes into that is how much adipose tissue they have. It also goes in the chronicity of use and how much they're using. But typically people have a lot of fat stores, tend to hold on to a lot more of that because the drug is distributed out and you have body stores of it essentially, right? So you can test for that, weeks after the last use of THC, and they'll still have positive amounts of it in the urine. That make sense? Anyway. So you will find that certain conditions can change this. So for instance, you have critically ill states. So if you were to have, say, edema building up for whatever reason, say acute kidney failure, burn victims can have drastically changed volume of distribution because they're losing so much body fluid. So again, there's a lot of things that can change this, especially in the critical care realm. So looking at the newborn infant, about 70 to 75% of their body weight is going to be just water. So this is why I mentioned big bags of water. You'll find they also have a higher extracellular water content greater than what you see with an adult patient. Less fat tissue, less muscle tissue. So these hydrophilic meds are going to have an increased volume of distribution. They have a wider amount of tissue that they can basically distribute into due to that water. So again, just think of kids having a bigger bucket than the adult would. So remember, the way you can think about this is because they have a bigger bucket, a bigger amount of water for drugs to distribute to, you need to give a bigger amount of dose based on a milligram per kilogram basis in order to fill that volume, right? So that way when you're measuring the blood, you get the same concentration as an adult patient, right? So again, you're going to see that usually the blood levels that we're going for are pretty similar between adult and kids. So for instance, if we're monitoring things like gentamicin, which is what type of drug? Right, what do you use that for? gram crackers, no gram-negative infections. You use that for a lot of gram-negative infections. You will find that you have to give a bigger dose on a milligram per kilogram basis to get the same concentration, because they're still shooting for the same concentrations as you would an adult patient. I'll give you an example of that in just a second here. And plus, it's really cute when you put kids in the precarious positions. Hopefully the parents are there to catch them, because I'm pretty sure if I did that to my kid, the bucket would be tipped over and their head would be bonked pretty quick. But anywho, so looking at the volume distribution, this is again gentamicin. It's a very common drug we'll use in the NICU, which I'll talk about that a little bit later on. We're dealing with these kind of sick newborns. But basically, we're going to find the volume distributions listed here. Here's the patient age, essentially so neonates, infants, and adolescents, and then the dose that we're going to administer. And again, these are basically designed to get the same serum concentrations, regardless of the size of the patient, because we've adjusted the dose based on the volume distribution. So little kids, because they have all this water here, they're going to have a much larger volume distribution. So say 0.5 to 0.6 liters per kilogram, versus an adult patient may only be 0.2 to 0.3. Okay, that means they get the same blood level. Because for those little kids, those neonates, we're having all this transfer of that the drug out of the blood and into that water compartment, the extracellular fluid. You're going to have to give 4 to 5 milligrams per kilogram per dose to get the same concentrations that you would have to give 1 to 2 milligrams per kilogram for that adult patient. Okay. So again, do you guys normally have to figure this out when you're looking at drug doses? No, they've done the work for you, but you need to know the concepts of why those doses are changing. Why you can't just give an adult dose to a small kid and expect everything to go fine, right? So not always the case, and here's a good example of that. You have to give a larger dose to fill that water volume in that tissue that the drug is distributing out to. Okay, other things you can find have decreased plasma proteins. You may find the protein binding, their protein stores are not going to be as high, so that can affect volume distribution. You can also find certain endogenous compounds actually compete for protein binding sites. You can actually see bilirubin maybe in higher concentrations, so you can get that newborn jaundice that can occur there due to high bilirubin. Normally it's being bound up by some of the serum proteins. And if you had something like a drug that came along and kicked that off, you could worsen that jaundice. And so that actually happens with a drug called ceftriaxone. You guys remember what type of drug that is? Cephalosporin, good. Remember what generation? Third generation cephalosporin. What do you use it for? Just everything, basically. Yeah, you use it for a lot of things. So meningitis, you could use it for UTIs that are particularly resistant. You could use it for potentially pneumonia, all kinds of things. So ceftriaxone gets a lot of use. One of the things you'll find, you can't use it within the first 30 days of life for these neonates, because it actually competes for the same binding sites as bilirubin. So if you were to give ceftriaxone to a kid during the first 28 days, you'd kick off and displace all that bilirubin, and all of a sudden they're jaundiced, right? We don't want to do that, so that we avoid that drug in that age group, and we use a different third generation cephalosporin. Usually use cefotaxime as an alternative, which we'll see that in the NICU section a little bit later on. But again, these are little things that you'll become familiar with, especially as you work with these patient populations more and more, and especially if it's something you want to go into professionally. You'll kind of get familiar with these things and just know that, okay, well, this age kid, I'm not going to use this drug, I'm going to use this one instead. Okay, a lot of protocols and things like that are built to already factor those things in. Another good example, so for instance, phenytoin. Remember phenytoin? We use that for what? Yep, so good anti-epileptic. High protein binding, usually about 90% protein bound for most adult patients. And so what can happen for these small kids is if they have, say, a decreased amount of proteins to bind up that drug, you're going to have a higher free fraction. What kind of implications does that have? More free drug means it's more active, right? It's going to be able to interact with those sodium channels on those neurons, right? And so you can see more toxicity related to that. So, that's when we have to monitor things like free levels versus total levels. Total levels will kind of find everything in the blood, including protein bound and non-protein bound. But due to those kids having smaller protein stores, may have a higher free fraction, you may see more toxicity. Even though the level looks good, the level looks fine, say, normal range is say 10 to 20, they may be 11 and be still toxic, right? So those are things to watch out for. Okay, so again, look and don't memorize this list. Just know that there's changes that occur here. Things like plasma albumin, pretty reduced in neonates versus infants. It will build up the stores over time. Typically, the more premature they come out, the smaller the protein stores are going to be generally, just because they need that extra time to develop those. But some of them may even may not be present, or may be present in reduced states versus as they get older. For instance, but things like fetal albumin typically is going to be present in the fetus or in neonates, but not present later on in life. So there are changes that occur. Don't have to memorize this list. Just know this is a factor that can affect them. Okay. Okay, so now moving on from the, we have the absorption, we've done distribution, now we have the metabolism, okay? So we'll look at some factors that can affect this, and certainly gestational age, postnatal age are going to be big factors here. Changes in hepatic blood flow. So less hepatic blood flow, what do you think that would do to metabolism? Or hepatically metabolized drugs? Decrease it, right? So again, if you have any kind of like congenital heart defect or something that's preventing a lot of hepatic blood flow, that can be a problem there, right? The size of the liver we're going to look at is typically enlarged compared to kind of the total body mass for the patient compared to an adult patient. That will have a factor here. And we're also going to see some factors of the quantity of enzymes, things like our CYP enzymes, and also the quality of them. So you're going to find that some of these systems are going to be immature as a kid's born, and some of them will actually be in a higher functioning state than an adult patient would be in. So we'll look at some examples of that in a little bit later. But certainly things like enzyme induction, inhibition, we've covered that already. Ad nauseum, I'm sure some of you've probably thrown up from talking about that at some point, right? Anyway, so we're going to look at some factors here. Remember your phase 1 reactions. Remember, and when you're thinking about what these reactions are doing to a drug, what do phase 1 reactions do? What's the goal of all these metabolism? So it could be to activate a drug if you had a prodrug, but what's the main? Typically, what's the main goal? To make it more water soluble so that it can be eliminated through the kidneys, right? That's the main goal of metabolism, right? Our liver is trying to get rid of all these drugs that we pay too much money for to put into ourselves, but we are trying to get rid of it typically, right? It's a detoxifying organ. So these reactions are meant to make them typically more water soluble in order to eliminate them through the kidneys. Certainly some of it can go through biliary excretion, but the main goal for most things is to get it more water soluble. So phase 1 reactions are typically doing that. So this is where we add something like a hydroxyl group or an amino group. These are not the same kind of conjugation reactions that we'll see in the phase 2 reactions, but these are typically either making the drug more water soluble with just a phase 1 reaction to have it eliminated, or it can go into a phase 2 reaction after this. We'll look at it in a second here. But this is where you see like your oxidations, which is where cytochrome P450 is going to come into play. That's going to be the biggest one we're going to talk about in relation to the changes that occur between, say, a newborn versus an adult patient, right? So typically you're going to find that CYP P450, most important one, this is the one we kind of talk about the most. You're going to find that when the kid's a full-term infant's born, this is just a full-term one, their CYP P450 activity is probably half of what you would see with an adult. And again, it's not going to be the same across the board that all of them are basically halved in their activity. Some of them will be much more deficient than others. Some will be more upregulated. Because remember, we're not just dealing with the CYP enzyme, we're dealing with CYP P450, the whole family. So there's 3A4, there's 2D6, there's 2C9. All these different things will have different levels of expression depending on the age and development of the kid, right? So looking at specific pathways, the phenytoin is another good example, as we mentioned here, that you can actually find that by 1 year of age, you actually will have more metabolism of that drug on a pound per pound basis versus an adult patient. So you may have to give higher doses, 2 to 5 times of an adult. And if you remember when you did your prescription on that, what did you notice about the dosing recommendations? How are they kind of broken up when you were looking them up in the references? So certainly there's like a weight-based component. You do this many milligrams per kilogram, but you notice there's different breakdowns based on the age of the patient, right? So that was one of the components. You had to go back and look at the age of the patient you're writing the prescription for to make sure that they fit into that category. Say, okay, well, a 2-year-old needs a lot bigger dose than you would say for like a 16-year-old, right? Hopefully you guys noticed that when you're looking at your references, right? Most everyone did the doses correctly. So again, you're noticing that there's going to be those age-based breakdowns, and you have to readdress that as the patient gets older, right? Because again, if you're seeing these patients for years and years, you need to make sure you're readdressing these things to say, okay, well, this dose was fine for them for a while, but now we need to go and maybe reduce that dose over time or change it in order to account for the fact they're metabolizing it differently, okay? So other things we may find decreased activity. So for instance, and you don't have to know these specific examples, just know that these are some of the things you can run into. These are concerns you might run into with these patients. They may have reduced ability to metabolize things like chlorohydrate. Anyone know what chlorohydrate is? Anyone ever heard of that? It's an old school drug we don't use anymore, but if you ever heard of the term like slipping someone a Mickey? Anyone? Seinfeld? Anyone? No? Go watch that episode. It's really funny. But you slip them a Mickey. Basically, it's they used to use this drug called chlorohydrate, and they would knock out people at a bar, steal their wallets, and then they woke up there. Oh, we got too drunk, and they'd kick them out. Anyway, it's an old school drug we used to use in neonates because it would stick around for a good long time. It was good for like neonatal abstinence syndrome, to try to calm those kids down a little bit. Anywho, now I'm feeling very dated, but you guys should watch Seinfeld. It's just a good show. Okay. I mean, certain things like local anesthetics may have decreased metabolism. Theophylline. Anyone remember what we use theophylline for? Yeah, we use it for asthma. So again, that can have altered metabolism. You may need to use lower doses in order to account for the enzyme function of the patient. So little things like that to think about. Okay, so getting into CYP450, so you're going to find that the different enzymes will mature at different rates. So for instance, CYP2E1 activity will start to increase within hours after birth, right? So it happens pretty rapidly. CYP2D6 is detectable, pretty soon after birth. 3A4, will not be present really till the first month, right? So again, drugs that get metabolized by those enzymes may stick around for longer because they're not really that ramped up yet. And then, at a certain point, you may find that things like 3A4 activity will actually outstrip an adult patient for a period of time. So again, when you're looking at these dosing recommendations, and again, you should look at pediatric specific recommendations, you'll see, say 1 to 3, you're going to dose it this way versus, say 4 to 6, it'll be dosed like this all the way up to adulthood. All right, phase 2 reactions. Remember, with phase 2 reactions, now we're adding something onto the molecule. So either we're adding like a methyl group or a glucuronide, we're conjugating that, glycine, something like that. So again, it's just different flavor of metabolism. Again, the main goal though is what? Increase water solubility for elimination, right? It's the whole goal of metabolism here. So this is kind of interesting because this also goes to inform why we use or don't use in a lot of cases certain drugs, especially in the neonatal period. So for instance, if you ever work within the NICU, you're going to know that when you're giving IV medications, you want to use preservative-free formulation. So what do we normally use preservatives for in our drugs? Yeah, increase shelf life, either to keep it sterile or, because again, we don't want to inject cooties into our patients, right? Or to increase the stability of it to make sure that the drug itself does not degrade over time. There's a certain one called benzyl alcohol that is a preservative that used pretty frequently for, and if you see a vial of a drug and it says multi-dose vial, it usually contains preservatives and things like benzyl alcohol. Well, those neonates, they can't process that benzyl alcohol, and so they end up developing this metabolic acidosis, and they get what they call neonatal gasping syndrome, where basically if you were to give this a drug that contained benzyl alcohol to them, they can't metabolize it appropriately, they get really acidotic, they're trying to blow off all the CO2, they get and eventually have this kind of this deterioration. So that's why recommended just use preservative free. Other examples would be things like chloramphenicol. It's an old school antibiotic we don't use too much anymore, but you couldn't give this to a neonate because it causes, they couldn't break it down appropriately, and you get this gray baby syndrome that occurs there. So lots of little drugs we don't use because they can't metabolize it appropriately, right? So once they kind of graduate from the NICU and they're a little bit older, then certainly you can give it to them, no problem, but you have to consider, this kind of first month when they're really kind of at risk for having these kind of issues, right? Okay, looking at the excretion, again, a lot of drugs are going to have some degree of renal excretion. Typically, you're going to find that the glomeruli, especially in the more premature the neonates are, the less functional they're going to be. And so when you think about like an adult patient, how do we gauge what their kidney function is? Use GFR, and we use GFR. How do we calculate that? Yeah, so we don't actually have a good way of detecting actual GFR, so we use a surrogate. We use creatinine clearance, right? Because then creatinine is not really absorbed a whole lot, it's not really secreted a whole lot in the kidneys. It's a really good surrogate, right? Remember the equation we used for that? The Cockcroft-Gault we talked about, how it factored in like the age of the patient, the weight of the patient, their serum creatinine value, and based on that you can figure out, basically what their estimated GFR is going to be, right? So that was a good way to gauge what their renal function is. However, for kids, you're going to find that's not really going to be super useful, and so instead, what else can you use to kind of monitor for kidney function? Urine output is going to be a big thing, right? So again, urine output is going to be huge. You can look for that in adults as well, but typically we're also gauging urine output, especially in the neonates, because again, we're going to find that there's some issues with creatinine for them, as we'll talk about in a second here. So again, we're doing things like weighing wet diapers, right? So you're monitoring for how much actual output they're having based on the weight of the diaper, things like that. Or if they have like a cath in, you can directly measure it by what's coming out. But you're going to find that renal blood flow can change based on disease state. So think congenital heart defects. Think about if they're on a nephrotoxic medication. We'll talk about that more in the renal section later on. But lots of things that can affect their urine output and their renal function in total. So typically what you're going to find is that for the first week of life in a newborn, you're going to find that their serum creatinine is increased. Why do you think that is? Whose serum creatinine are you really measuring at that point? The moms, right? So you'll actually find that typically, kids do not. Again, we mentioned the muscle mass for a neonate is what? pretty low, right? They're not, unless you have like some kind of bodybuilding baby or something coming out, which you don't see too often. But you should have a decreased muscle amount, and again, less muscle means less creatinine, right? So again, you're actually measuring this falsely high creatinine. That's usually for mom. So you can see that you'll see in the first week you'll measure it, but it's not super useful in actually calculating what the renal function is doing, right? Because we're only using creatinine as a surrogate for what the actual GFR is going to be in those calculations. But during the first 1 to 2 weeks of life, you'll start to see renal function start to really pick up, and you're going to be measuring urine output. Typically, what we're going to measure for, and I won't quiz you on this specifically on the test, but typically we're looking for greater than 1 ml per kilo per hour of urine output. That is generally going to be considered good urine output for a pediatric patient. Okay, so again, it's always nice when you can remember things just one something per something. Like that's always a good and easy thing to remember. But 1 ml per kilo per hour is typically good urine output for these kids, right? Usually like an adult, it's like 0.5 to 1 you can get away with, but for kids, like 1 or greater is usually pretty good. But anyway, preterm kids are typically going to have a reduced GFR just because they have more immature kidneys. Their nephrons and glomeruli just really haven't developed yet. So you may see also reduced renal blood flow. All these things are going to have take a hit on their renal function, but will develop as they continue to mature. So looking at, say, the postnatal age, looking at a term infant versus a preterm, and again, usually you'll kind of gauge these kids based on the weight as they come out. So again, 2 grams basically is another way to say what? What's a more common unit we use to weigh kids or adults? So kilograms, right? So like 2,000 grams would equal how many kilograms? 2 kilograms, right? Kilo means 1,000. So 2 grams or less than 1.5 grams baby, or less than 1.5 kilos baby. So you have very, very small kids. But looking to see how preterm they are based on their weight, you can see here that their GFR, if you're actually to calculate it, going to be much, much lower. So again, even at 15 to 16 days of the postnatal age, again, these kids are still not term at this point, right? So they still should have been cooking the mom, but for whatever reason, they made their debut a little early, but they still don't have that same kind of mature kind of glomeruli that the full-term kids do. Does that make sense? So it takes them some time to kind of catch back up in the long run. Okay, so looking at estimated GFR, looking at neonate, say about a month old, you're going to see around 30 to 40, but typically by the time they're around 6 months to the toddler stage, they're probably around adult levels, and so you can kind of use and again. Renal issues in a lot of these patients are not super common, so you can kind of say that yeah, most of these kids probably have pretty good renal function by the time they're about 6 months old or so. Okay. So that kind of goes back into showing, okay, what's the half-life for these drugs? How is that affected? Because again, if you decrease the amount of renal blood flow, if you're decreasing the amount of urine production, that GFR, especially for water-soluble medications that need to be eliminated through the kidneys, that does what to the half-life? Should increase right there because the drug's sticking around for longer because they can't clear it as well. So again, going back to gentamicin, because this is another common drug we'll use in the neonates, say if they're a neonate less than a week old, their half-life may be pretty variable. And again, a lot of this goes back to just how mature they were, what their gestational age was, and range between 3 to 11.5 hours. Pretty big range there, right? So that's why when you're looking at your dosing recommendations, you'll see that they'll look at, okay, well, were they gestational age less than 37? And they're in that first week, you're going to dose it like this, right? You may be dosing every 24 hours versus the more premature they are, you may dose it every 36 hours or every 48 hours because the drug is sticking around for longer. You don't want those levels to build up, right? Because you can see toxicity from that. And remember what toxicity you can see with gentamicin? Ototoxicity and nephrotoxicity is the other big one, right? So those are things you want to avoid because, again, they're already not clearing the drug super well to begin with. So that's why we have these different dosing recommendations. As they get older, they're going to see the half-life is going to go down, and so you would dose these drugs typically more or less frequently. The half-life gets shorter, we'll dose it more frequently, right? So traditionally, you would give gentamicin for an adult patient every 8 hours. Nowadays, we don't do that so much anymore because we know it's a concentration-dependent killer, but it's really neither here nor there. Just know that this is why we give the drugs less frequently for these neonates, is because they can't clear it as well due to the kind of immature kidney function. All right, let us continue. Any questions from the first half? A little bit of review, but as a good refresher, get you guys thinking about drugs and kids. I make a profession out of giving little kids drugs. Professional drug dealer, if you will. No. Actually, I just had a good case. I was working yesterday, and one of my coworkers texted me about this kid. And so basically, we were working up in Central, and we had a call from the ER. It was one of the nurse practitioners down there, and she said, "Hey, I got this kid. I think he was 6 years old. And he, I think he has pneumonia. but he has listed on his allergies amoxicillin and cephalosporins, and the reaction is rash. So she's like, well, what the heck do I give this kid? So the question I pose to you is, what the heck do you give this kid? What do you do? Fluoroquinolone? Well, that's kind of interesting. Now, would a fluoroquinolone work for pneumonia? What does that cover? So we give so an example of a fluoroquinolone we can give would be what? Levofloxacin, we could do that. What does that cover for? You get your atypicals covered, right? So like your mycoplasma. We covered. What else can that cover? What's the other big thing you worry about with pneumonia? Maybe an MRSA, but not usually like in a 6-year-old. I don't think that. Not Pseudomonas so much, unless it's like, in the ICU. He's not that sick. He's just coming to the ER. Yes. So we'll get to that in just a second. What's the other thing you have to worry about with pneumonia? The other bug. Strep pneumo, right? Strep pneumo, H flu, mycoplasma. Those are the kind of the big ones you think about, right? So again, bugs and drugs. You got to know your bugs if you're going to know your drugs, right? So what does macrolide cover? Atypical, right? So only going to get atypicals with the macrolide. The fluoroquinolones, you do get coverage for most of your pneumonia stuff. However, you worry about strep resistance, right? Because again, we overuse it. We're going to get a lot more strep resistance as time goes on. So that could be a potential thing. In a lot of cases, when you're looking at guidelines for a lot of infectious diseases, you will find that a fluoroquinolone is a good backup if that's kind of like your a lot of ENT, upper respiratory tract stuff. Like you'll find the quinolone can be a good backup. Usually not the first line though, in a lot of cases. Okay, so that's one option. The macrolide could get our atypicals. However, it may not get that strep. So again, the question is, okay, well, what else could we do? Like, what do you think about those allergies though? You know, they're legit. Like, do you think? What can we do? I like that. That's one of my favorite tricks I like to use. So you can give them a dose in the ER. If you don't suspect that it's actually a true anaphylactic allergy, you can go ahead and try to give them like a test dose in the ER and monitor them for a period of time, like say like an hour or so, and see if they have any reactions. If they don't, then they're generally good to go. You can give them the rest of their prescription and they can go on their way, right? I like to do that in a lot of cases. Another alternative we could use to get things like strep pneumo, which is gram positive or gram negative, or gram cracker. Gram positive, right? So what else could I use to cover that? Something like only covers gram positives. It's vancomycin, which I wouldn't use for this kid because it's going to be outpatient therapy, but it's a good thought. What's the other thing that really only covers gram positives? Clindamycin, right? Remember clindamycin? Clindamycin really only covers anaerobes and it covers gram positives. That's only two things that it does. So clindamycin would have been a decent backup as well, and that's actually what we ended up recommending. The nurse practitioner did not feel comfortable doing a test dose, which that's a lot of times what I've run into with a lot of providers is that they have a hesitancy because who wants to give their patients an anaphylactic reaction? Right, no one's going to raise their hand to that. So some people are hesitant to challenge that. Some people are a little more gung-ho, but that's usually the conversation. So she was not comfortable giving a test dose of something like amoxicillin, which is usually would be a good first-line drug for pneumonia in that age group. Wasn't comfortable with that, so she said, okay, let's go ahead and do clindamycin. So send the kid home. Now I get a text from my coworker who said, oh, by the way, the kid had an anaphylactic allergy to clindamycin. Now he's admitted. We're like, oh, wah wah. Again, one of those things you just couldn't predict. Like, some people, you have one drug allergy, you tend to be more allergic to other things as well. It's just kind of how it goes. So again, not something we could have predicted. However, it's good if you give a test dose in the ER if you're especially worried about any kind of reaction. Give a test dose there and then see how they fly. If they don't, they crash and burn like this kid did. They get admitted, get treated with what would we give for that anaphylactic allergy? Epi would be a good one, right? So we can give epinephrine, give what else? Benadryl, steroids, right? So again, all those would be our main treatment for dealing with an anaphylactic allergy. So again, not a story of the necessarily happy ending, but again, thinking through these kind of scenarios or that's what you're going to run into on a day-to-day basis out there in the real world. Anywho, enough of that tangent. Going back to our kidney function. Basically, you're going to find that as far as like drug secretion and reabsorption from the renal tubules tends to be a little diminished in that first year of life. But again, looking at things like renal blood flow, looking at the pH values of the kidneys, usually it's a little bit lower than what you would see kind of normally. These can all affect the degree to which drugs will be either reabsorbed or secreted, which can have factors on their elimination. Okay, so anyway, so that's kind of the main kinetic features of pediatric patients, mainly like neonates, kind of the early period where they're kind of early developing. Now, looking into kind of diversity of these drug responses, like what are the different things that play a role in how we're actually going to be, the kind of the dynamic factors of some of these things. And so we've already seen some of these in the past, where like things like genetic polymorphisms can affect how patients can metabolize drugs. We can see how certain patients are more sensitive to drugs than others based on some of these genetic polymorphisms. But certainly, again, looking at their age, looking at their physiology, even some things like hormonal status can affect the way that some of these drugs are cleared as well. So lots of things go into this, and we'll look at some of these features here in just a second. Now I mentioned, remember codeine. Remember codeine is what type of drug? Opioid, analgesic, right? And what does that get turned into? Morphine. So remember our example, that 2D6 enzyme is really important for doing that. And we mentioned it's a black box warning now on codeine that those patients who may be at risk for having maybe hypermetabolizers of CYP2D6 can produce a lot of morphine, and that can cause respiratory depression, CNS depression, and has led to some deaths there, right? Some kids though, they tend to have diminished responses, right? They have low functioning CYP2D6. Maybe they don't produce a lot of morphine from that. The drug doesn't really work that well, right? So again, just going to be dependent on several features. This can be one of them. And again, is there a good, easy test to do for these patients for these kind of polymorphisms? Not typically, right? It's usually pretty expensive. You wouldn't do this in very many patients, if any. It's just easier to say, well, I'm just not going to use codeine. I'll use something else instead. And we know, as you've already been tested on yesterday, that you have a plethora of different opioid options you can utilize as an alternative, right? So you could use morphine itself. You could use fentanyl. You could use Dilaudid. You can use all these different options. You don't have to use codeine. You just have to change the dose, right? Because again, they can all be equally potent if you use the right dose. Okay, so looking at actual dosing regimens, again, we talked about you can have age-based dosing regimens that can be utilized. So for instance, have, say, between 2 and 5 years of age, give this dose. Between 6 and 12, give this dose. Now, what are the kind of the downsides of using this kind of regimen? Yeah, bigger kids or smaller kids. You can have kids that are in the extremes of weight in either side that can be really affecting this. So if you have a pretty big 4-year-old who may be maybe bigger than what a 12-year-old might even be, and you find some cases where it's pretty extreme like that, that dose of 2.5 to 5 milligrams probably isn't going to cut the mustard, right? So again, you may need to look at more kind of patient-specific ways of dosing these drugs than just looking at the age themselves, right? So, but easy to use in practice. You'll find some limited use cases for this, but usually going by the wayside in a lot of cases. Other things, body weight dosing. This one's going to be the most common. You've already practiced this quite a bit. I'll have some practice examples here we can look at again in a few minutes. We'll kind of work through. But again, using a milligram per kilogram per day per dose. Remember, look at your units. Make sure you're looking at that appropriately, because we'll see some places where that can kind of goof us up a little bit. But again, it can change based on whether you're dealing with a neonate, dealing with an infant. But obviously, do not go above the adult doses. You're just asking for trouble, more likely to see toxicity with that. Just kind of cap it out at the adult dose. Again, most common. However, you may have some kids who are clearing things differently than others. That doesn't really take that into account. So again, look at things like renal function, look at hepatic function, see if that you need to change your dose based on that. Because usually your drug references, they'll have like listing for like the typical dosing, they'll have like pediatric dosing, and then they'll have say dosing in renal dysfunction or dosing in hepatic dysfunction. Look for those areas as well to see if you need to adjust based on your patient. Again, disadvantages, you may have a potential for overdosing or underdosing in overweight children, so just be aware of that. Kind of watch out for those kids. And of course, this is an increasing kind of epidemic of childhood obesity, so just be aware of that. You need to be a little bit more cautious when dosing those patients. Okay, we also have BSA, or body surface area. So an example of this would be like corticotropin. You may use this as 150 milligrams per meter squared. So again, when you're looking at body surface area, it's taking into account their weight, but also what else is it taking into account? Whether a feature of the patient. Their height as well, right? So you're using height and weight. And so again, this is getting even more specific with their dosing. It's more complicated of a calculation. Usually just use like an online calculator to figure it out. But we use this as the extremes of weight really don't have as big of an impact, because again, you're taking the height of the child into account as well. So we do this a lot for our hem-onc patients. So we do this I was doing this all day yesterday, basically, for a lot of our chemo kids. We're doing their dosing calculations where you dose something like, say cyclophosphamide. We're doing like 1,500 milligrams per meter squared, and you have to calculate that out, figure out how much the kid's actually going to get specifically. there's lots of different varieties, so make sure you're being consistent with what one you're going to use. So they'll give you slightly different answers, which may be clinically important in some of these smaller kids. So make sure you're using the same one that your institution, whatever their standard is going to be. Sometimes it can be difficult to get height in children if they're kind of squirmy, or imagine if you have like a little infant, they're not really being too cooperative and they're kind of like scrunched up. Like it can be hard to get an actual accurate height, and so that can be a factor here as well. You may have two different people measuring the same kid and may get two different results. So always keep that in back of your mind. Okay, so again, looking at intravenous drug administration, how to actually get these drugs to these kids. This is a very easy way to screw up and harm a child by screwing up giving a drug intravenously. So you have to look at things like, okay, where's the actual site that we're going to be administering this drug? The volume of drug is important as well. So when I say volume of drug, I'm kind of referring to what? Kind of go back to the concentration of it. How much actual fluid do I need to give this child? And again, if you're dealing with a 1 kilogram child, a neonate, like that can be small volumes being administered, especially if you're giving lots of drugs, multiple drugs. That can be a large amount of volume for that child. And you may find that you can actually dilute out the blood. You can see their hematocrit and hemoglobin drop. You can run into issues like that. So you have to be really careful with like the volume of drugs that we're giving. Typically, we try to shoot for more concentrated drugs if possible. It may not always be possible, especially with some drugs being more irritating to the veins, the higher concentrations. But just know that is one thing we will consider when giving drugs intravenously to these kids. We'll look at things like, giving multiple drugs and their corresponding frequency. Typically, if you have to give drugs multiple times, try to condense them down into just one administration if you can, but that's not always possible due to some things being Q12, some things being Q8. So there's some scheduling difficulties there. And then we'll look at some of the mechanical features here in just a second, like pumps and things like that in a second. Now, when do you think therapeutic drug monitoring might be a problem, like drug sampling could be a problem in a neonate? Because we have to take blood in order to get a drug level. Again, and usually you'll have things like micropipettes and things like that you can use to use a smaller volume of blood, but you need at least a minimum amount of blood to run that test on in the lab. So again, if you have multiple sticks, multiple labs being drawn, guess what? Again, you can make that patient potentially anemic, right? Drop their hemoglobin because you're taking all their blood out of them essentially, right? So this is one of the things where you have to consider, like, okay, well, can I add on my Vanco trough or my Gentamicin trough onto the other labs that are getting, these are the considerations that, our nursing buddies are going to have to think about. These are things you need to consider when scheduling out a lot of these labs. Okay, so a lot of times what we'll use is a mechanical pump in order to make sure we're infusing a very specific volume into our patients at a very specific rate, right? Because again, if we give it too fast, that can be an issue. If we are giving too much volume, that could obviously be an issue. Because again, if you're pumping a ton of fluid into a small neonate, like where does that fluid eventually end up? Even so much, it's going to eventually go into the kind of interstitial spaces, and eventually it's going to go into the lungs, right? And so you can cause pulmonary edema, and we've seen that where cases where someone hung up a liter of normal saline, not hooked up to any kind of infusion pump setup like this, and infused the whole thing into a neonate, and the kid died, flash pulmonary edema from all that fluid just accumulating in the lungs. Not something you want to typically do, right? So this is why we have a lot of safety features built in. So we have these mechanical pumps. Typically they'll have like libraries built into them. So for instance, this is a syringe pump used for smaller volumes. You can basically put this in. Notice here how this little component here fits over the syringe. This can actually tell what size syringe you're using. So again, if it gets pulled out further, you're using a wider diameter syringe, and so it will adjust how fast it's going to be pushing that in order to make sure you're getting the right amount of drug in there, right? So actually it'll come up and say, hey, is this a 10 ml syringe? You say, yes, that's a 10 ml syringe. And you can program in the rest of the stuff. And so, we'll program in, the right concentration of the drug, how fast you're giving it, how much to give it. All those things get featured into here to make sure you're not giving the wrong amount to your patient, right? So looking at oral administration, how should you administer oral medications? So some of these questions come up on the prescription writing thing, because usually you're dosing a lot of these drugs in what for kids? And usually in mLs, right? And so again, the question is, well, how do we used to do it? Teaspoons, tablespoons. How much is in a teaspoon? 5 mLs. Usually 5 mLs or so. It depends if you maybe if you go to IKEA, you get like a Swedish spoon, maybe it's a little different. I don't know. Not all spoons are created equally is the point there, right? You may have one that could be 6, one's 4. It can vary pretty widely, right? How much is in a tablespoon?
15.
Usually 15 mLs, right? How many of you guys knew that before I taught you guys that in pharmacodynamics? Not everyone, right? So again, it's one of those things where it's confusing for patients. It's just easier to say take 2 mLs. And how do we measure that usually? Yeah, use a syringe, and actually, like sometimes some of these oral liquids will come with like a little cap that you can pour the drug into. And I was measuring that myself because I'm a nerd, and I poured it out. I said, okay, well, my kid's gonna get 5 mLs of Benadryl. I poured it out, and we were trying to knock her out so she would actually go to sleep. She was teething really bad that day. Besides the point, actually, it's incriminating. I'm gonna cut this part out, but. Don't tell DCF. Anyway, so I measured it and said, okay, 5 mLs on this little cup, and I actually drew it up in a dosing syringe, and it was like 6 mLs. And I'm like, what the heck? You know, because again, if you're looking at it wrong, you have to find where the meniscus is and all those things. You don't want to worry about that. It's just easier to use a dosing syringe. So again, most pharmacies will have that available. If you go and ask for one, you can have it. You know, patients have easy access to this. So again, draw it up in a dosing syringe so you can get very specific. Just 2 mLs, 2.1 mLs, they can measure that. And that's no problem, right? Now, again, you have to look at things like the sensory appeal of the dosage form. You know, do kids typically like taking medicine? No, not typically, right? And so again, we have ways to like flavor it, things like that, but does not always mean. Oftentimes, the kids will have kind of a just a psychological sort of stigma against, you know, as they hear medicine, they think bad things, right? They think shots, they think pain, they think bad taste. Nowadays, the medications taste way better than they did, at least when I was a kid. You know, like orange flavored ibuprofen and grape flavored Tylenol and all these things. You know, so it's not an uncommon call at the poison center and say, you know, little Johnny just drank an entire bottle of Tylenol. So, well, it shouldn't make it taste so good, but that's the only way they're actually going to get it into them in the first place. Anyway, these are things to consider, right? Look at things like drug-food interactions. What are little kids typically drinking a ton of? Maybe Gatorade. But what's the other thing? Good for the bones. Milk. They drink a lot of milk, right? So again, milk binds up with a lot of drugs. So fluoroquinolones, you can bind up things like tetracyclines, which why shouldn't you give tetracyclines to kids? Yeah, really teeth staining, right? So you worry about that. So we wouldn't give those kids, but lots of other things. If they're on levothyroxine, that hypothyroidism, that combined up with calcium, think about these things as food-drug interactions. You have to separate that out. And you mentioned inactive ingredients. A lot of times when kids have an allergy to a medication, it's not necessarily to the drug itself. It's usually one of the other things that are formulated into it. So, for instance, a lot of dyes, kids can have allergies to, like red number 3, I think is a big one that have allergies to. These are things to consider as well, right? Doesn't mean they can't receive that drug ever again, just probably not that formulation that has that dye in it. So a lot of times we'll have to have dye-free formulations that are available as an alternative. Okay, so again, when prescribing, make sure you get the most up-to-date weight available for that kid, right? So do you guys think I know exactly how much my kid weighs right now? Either of my kids? Actually, I don't. I have no idea. I can kind of guesstimate it, but if my kid had an emergency, if they stop breathing on me all of a sudden and you get them to the ER, they say, how much does your kid weigh? I'm gonna be like, I can't give you an exact number, right? I can kind of give you a ballpark answer, but when you're dealing with like code meds, do you want the ballpark answer? You want exact amounts, right? So again, a lot of parents don't know that either. You need to be kind of careful with that. Make sure you get the most up-to-date possible. Make sure you're being consistent with what weight you're using. So again, weight in kilograms and pounds. Usually we like to err on the side of using kilograms. Just always use kilograms. Did you guys notice on the prescription what was the weight I listed? It was in pounds, right? So again, if anyone missed that pounds conversion, you're going to give too much high set to your patients, right? Because how do you convert from pounds to kilograms? Divide by 2.2. So if you're using that too high of an amount, if you're using that pounds, you're giving 2.2 times the amount of high set to that kid and possibly causing respiratory depression, right? I don't know if, hopefully none of you guys did that, but I will grade those soon and we will find out, right? So see a few sheepish looks like, oh gosh, I didn't notice that. So those are things to consider. You know, a lot of times, have you guys ever heard of a Broslow tape? Ever like working in the ER or a Broslow tape? So basically, when you're dealing with kids in you know, cardiac arrest or any kind of like code type of emergency, a lot of times what we would have is this tape called a Broslow tape, where basically you would kind of pull it out, you'd lay it along the side of the child, and kind of figure out basically what color they were based on where their feet landed on that. You kind of start at the head, go down, it might be red or pink or yellow, and based on that, that gave you a range of weights that they were. So for instance, yellow might be like 11 to 13 kilograms. I don't know if that's right, but you can double check me. But based on that, then we'll say, okay, well, here's all the size of equipment that you need. Here's the size of ET tube you're going to use, and here's the dose of medications you're going to use. But again, if you're only using height off that case, you can run into obese kids, really underweight kids. So there's a lot of inaccuracies that can happen there. And in fact, we had our when we first started our ER at Nemours a couple of years ago, we had our beds that were there, and they had scales built into the beds. You think, oh, sounds great. The question is, what's the lower end of that scale? It's actually, you know, a bed designed for an adult patient. If it only goes down to like, say, you know, 30 kilograms, guess what? If you put a 1.5 kilogram neonate on there, guess what? It's not going to read it necessarily as accurately as you'd like. These are all things to think about when you're dealing with these really kind of at-risk kids. Okay, make sure you're double checking your doses with available resources. So Lexicomp is really good. Micromatics is another big one you'll see in a lot of institutions. If you're doing neonates specifically, there's a book called Neofax, which everyone in the NICU is going to be very familiar to use or be familiar with using. So just make sure you're using kind of what the standard is for that for your patients. Now, counseling points with children, if you're trying to actually convey information to them, you need to make sure it's patient specific. So again, if I'm trying to talk to a 3-month-old, is that going to do a whole lot of good? Probably not. They're probably going to like burp at me or throw up or something. I don't know, whatever. That's what usually my kid does. She kind of smiles and throws up on me, and that's our conversation. But you have to tailor to your audience, right? So again, a 2-year-old, as you saw, is way different than a 16-year-old. So make it specific for them, but make sure you're kind of counseling the guardians, whoever's going to be providing care for that patient. Okay, so let's do some drug dosing calculations. You guys already are like practice experts at this, right? Yeah. Yay, you guys have all done. I've seen very good calculations so far. I haven't done the second assignment yet, but I will soon. We'll see if it continues on. But let's say we have a 15-kilo child who's getting amoxicillin for acute otitis media. The dose is going to be 90 milligrams per kilogram divided BID, which means twice a day. So we're going to get every 12 hours essentially. And the suspension comes as a 400 milligram per 5 ml suspension. So how much should this kid get? So what are the steps? What do we do?
90 times 15.
So you're going to do 90 times 15? Okay, so you can do 90 times 15. Actually, I think I have the steps listed out here. Do I? Right, so a dose per day. So again, remember, keep your units straight. So again, this is per day. We're going to do 15 kilograms times 90. We got 1350 milligrams per day. Okay, so I mean that's the total amount they're going to get. So then what do you do with that? Divide it by half, right? Because again, they're getting twice a day. So you divide it by half. So we're getting 675 milligrams per dose. And then what do we do with that? You can divide by 400, or you can divide by 80, right? Because 400 divided by 5 is 80 milligrams per ml. This is one of the things I run into, and it kind of drives me crazy. Is like everything. It would be great if everything was listed as milligrams per ml, but a lot of times you'll find milligrams per 5 mLs, and again that goes back to the teaspoon kind of old nomenclature we used to use. I don't really like that as much. It'd be much nicer because again you can run into issues where if you thought that was 400 milligrams per ml, and I saw that a few times on the phenytoin prescription for the first assignment. I saw something that was like 125 milligrams per ml instead of per 5 mLs. That's a very different concentration, right? So again, these are things to consider. So again, you can do that 675 divided by 400, and that will give you how many 5 mLs basically you would need. But more likely, I would just do 675 divided by 80, right? I think I have on the next slide. 675 divided by 80 is going to be 8.4 mLs per dose. Not per day, but per dose. Okay, so make sure it's very clear. So that way that when you write the prescription out, say take 8.4 mLs, PO, BID. One thing I forgot to mention for the prescription assignments is read it out loud before you write it. If you sound like Yoda, there's probably some room to improve there, right? There's a few I remember seeing that said like PO take 4.2 mLs mouth by, and I was like, this looks weird. And it was like it hurt my brain to like try to parse out what, like it was all correct. It was just the order was very strange. So just read it out loud. If it sounds funny, maybe consider rewording a little bit. Anyway, this is why we're in school. We learn things and get better at it. So by the time you get out there, you guys are gonna be rock stars, right? Okay. So again, very straightforward. This is the same process we do, whether it's an IV medication, whether we're doing it for code medications or amoxicillin. It's all the same process here, right? So let's say, and I don't think I did wrote them out, so I'll write them out on these slides, but let's do it together, right? So I'm gonna get my calculator out. I'm not texting or anything. Okay, so 18 kilogram patient, they have Zantac for their GERD symptoms. We're gonna do 4 mg per kilo per day divided twice a day. Okay, and the syrup comes as 15 milligrams per ml. So how much should they receive per dose? So what's our first step? So 18 times 4, so 72 milligrams per day, right? Because they're getting 4 milligrams per kilogram per day, so they're getting 72 milligrams per day divided BID, right? So you take that 72 divided by 2 equals 36, right? So we have 36 milligrams getting per dose, and then what do you do with that? Divide by 15. So divide by 15. What do we get? 2.4 mLs per dose, right? So we're going to do 2.4 mLs per dose, so they would receive twice a day. Okay, good. Very straightforward. How about we have a patient, 12 kilograms, getting trimethoprim sulfamethoxazole for cellulitis. They're getting 4 milligrams of the trimethoprim per kilo per dose divided BID. How much did they get? Here's the concentration. Sulfamethoxazole 200 per 5, and trimethoprim 40 per 5. How do we start out with this? 12 times 4. Good. So they're getting 12 times 4, which is, they're getting 48 milligrams of trimethoprim per dose, right? So we're already at per dose. We don't actually have to divide it. You do it per dose, right? So we're going to do 48 milligrams, and then what do you do from there? Yeah, so again, when you get the concentration, we're going to break that down into per ml. So it's 8 milligrams of trimethoprim per ml. So we're going to take that 48 divided by 8, right? Because 8 milligrams of trimethoprim per ml, and that's going to be 6 ml. So the kid's going to get 6 ml twice a day. Everyone with me? Everyone feel pretty comfortable? Do you feel like you're a little bit more comfortable after doing these prescription assignments? Feel like at least if I put a gun to your head, you could do it? Essentially, I'm kind of playing like an academic gun against your head, like, I'm going to do it. So anyway, yeah, so again, the point is to practice with it, because again, when you work only with adults and all of a sudden you're stuck with a pediatric patient, what do most providers probably feel? A lot of apprehension. You're really worried. A lot of people feel very uncomfortable working with kids due to the fact they just don't have practice. Yes?
So in regards to suspension, because you also have the sulfa there, I mean, I see that you just do in the trimethoprim, but is there a time where you have to do both together and calculate it that way?
So because the drug comes as a fixed combination, that ratio is never going to change. You automatically get so much ever sulfamethoxazole built into that. It's just the standard is to dose based off the trimethoprim, right? And again, when you're looking at the references, you'll see that. Say, okay, we're dosing it based off the trimethoprim content. Right. Similarly, if you were looking at the high set solution that we mentioned that was on that prescription, well, what were you dosing it based off of? The hydrocodone or the acetaminophen? You're dosing it based off the hydrocodone component, right? Because again, it comes as a fixed combination. The same ratio of acetaminophen is always going to be there to the hydrocodone. That never changes. So again, I'm dosing it, and you'll see that in the references, dose based off of the hydrocodone component. Okay, so you do 0.1 or 0.2 mg per kilo per dose of the hydrocodone, and then you just the acetaminophen just kind of comes along for the ride, right? That's the way you can kind of think about it.
I got a question.
Yes.
So it says trimethoprim/sulfa. Do you always dose off the first one?
Not always. I could have put sulfamethoxazole, trimethoprim. That can change, right? So that's why you got to be really vigilant and looking to see like, okay, what is the actual concentration here? Because again, if I put it here for the concentration, I put sulfamethoxazole first in that point. So again, it can change depending on where you're at and what kind of bottle you're looking at. So, everyone with me so far? All right. How about we have a 20 kilogram child receiving 2 teaspoons TSP of acetaminophen 4 times a day for fever. The usual dose is 15 mg per kilo per dose, and here's the concentration. It's 160 per 5. Is the child being dosed appropriately? I have this question come up a lot. I say, hey, mom says I've been giving this much to my kid. Is that right? Is that too much? Is it too little? So let's figure it out, right? So based on the size of the kid, we have 20 kilograms. What should his dose be? To do 20 times 15, right? So 20 times 15 is going to equal 300 milligrams, right? So their dose they should be getting for their fever is 300 milligrams. Now the question is, what's the concentration of the acetaminophen? How many mLs should they be getting? So 160 divided by 5, does anyone know what that is off the top of their head? 32. I only know that because I work in Peds. But so we take 300 divided by 32, right? So we do 300 divided by 32. You get 9.375 mLs would be this child's dose, right? So the question is mom dosing appropriately? So 2 teaspoons equals what? 10 mLs, right? So is the kid being dosed appropriately? Get a little extra? That's okay. Again, within a certain range, you're generally fine. If you need to round within 10% or so, you're generally good to go. And in fact, we have protocols and things like that in the hospitals usually where we have dose rounding capabilities. And from the pharmacy standpoint, if you write for something that's like 9.1 mLs, we can just round down to 9. It's just easier for everyone. It's easier for the nursing and everyone involved if we can do that. So usually 10%, you're generally good to go, right? And some of you probably were already doing some rounding for your prescriptions you were filling in, right? So if it came out 2.1, you said, oh, I'm just going to round it to 2, you're probably fine in most cases, right? All right. Now remember our fluids. Remember how to do this? Remember the rule, the 4-2-1 rule for fluids for kids, right? So this is for IV fluids we'll be administering. What's the 4-2-1 rule? 4 mLs per kilo per hour is their maintenance rate, right? So 4 mLs per kilo per hour for the first 10 kilograms. You do 2 mLs per kilo per hour for the next 10 kilograms, and then 1 ml per kilo per hour for every subsequent kilogram. Right? So, and then the fluid bolus is always going to be 20 mLs per kilogram. Again, usually cap it out like a liter or 2, right? You wouldn't want to go above that, but most kids don't as I get up to that, let's say like their adolescent size. Anywho, so for instance, if we had say an 8 kilogram infant, what would be their fluid rate, their maintenance rate? 8 times 4, right? Because again, they're not even 10 kilograms, so they're just going to be 8 times 4. So again, 32 mLs would be their fluid rate, 32 mLs per hour for them, right? What would be their fluid bolus? 8 times 20 would be 160, right? So again, you'll get pretty good at doing this if you work with these patients frequently. I mean, we do these all the time because we have a lot of fluid orders that come through by providers, and then just double check it real quick and okay, that makes sense based on their size, etc. How about 1.2 gram neonate? So 1.2 gram, or I'm sorry, 1,200 grams is 1.2 kilograms. Sorry if I said that incorrectly. But 1.2 kilograms, so 1.2 times 4 is 4.8, right? So 4.8 would be their fluid rate per hour, right? So again, very small amounts. If I were to accidentally hang up a liter and just let it run, I could definitely go over that very easily. You can get into some big trouble, okay? How about a 45 kilogram adolescent? So for the first 10 kilograms, they get how much? 40 mLs per hour. For the next 10, they get 2 times 10, which would be 20. So you get 20 for that second 10 kilograms. Now we're up to 60 mLs an hour now. And then you have an additional, what, left over? 25 kilograms. And so that's going to be what? 1 ml per kilogram per hour at that rate. So it's going to be 40 plus 20 plus 25, 85 mLs an hour, right? Good. Again, more practice, you'll get used to this. Just change the numbers and you can practice all day long. How about a 100 kilogram teenager? Same thing. 40 plus 20, and that accounts for your first 20 kilograms for the patient. And then how much do we have left over? 80. So it's going to be 80 plus 60, 140. So you can do 140 mLs an hour, and that would be appropriate for that patient. Okay? Just practice. There'll be a couple of easy, it won't require a calculator on the test, but there'll be some easy calculations that might come up on the test there. Okay? Freak anyone out, but yep, math can be hard, but we'll make it easy for you guys. All right. Okay, this is something that comes up in the ER with some regularity. I have a lot of questions where kids will come in with a laceration, they need it sewed up, and what do we do you necessarily give them like a big dose of morphine to really just knock them out? Not typically, right? Usually we can use local anesthetics, and so we use things like lidocaine to try to numb up the area, and that will allow the whoever's doing the suturing, suture it up, and then patient really doesn't experience a ton of pain associated with that. So I get a lot of like, well, how much can I actually give? How much lidocaine can I administer? And so this is an example that where we do this calculation in the real world. So for instance, say I have a 24 kilogram patient getting lidocaine 1%, which is a pretty common formulation that we would get, usually like 1% or 2% we're going to use. And we're going to get this intradermally for a laceration. They have a laceration of the face, so we're going to give them numb them up a little bit and sew that up. So remember when I said when I said 1%, that goes back to talking about the concentration. How do I convert that to milligrams per ml? Do you remember? Move the decimal place over one spot, right? So I know this is a 10 milligram per ml solution of lidocaine. Okay, that rule works for everything. If you see a percentage, just use that, and you're going to be golden, right? So then you have to know what the max dose of lidocaine the kid could receive is. And so, 5 milligrams per kilogram is the max that they can get at one time. So 5 times 24 is 120. So they can get a total of 120 milligrams of lidocaine 1%, right? So the question is, well, how many mLs is that going to be for them? So what would I do at that point? Do 120 milligrams divided by the concentration, which is 10 milligrams per ml. And you're left over the volume. So it's going to be what? 12 mLs they can receive. So you can inject a total of 12 mLs before you would worry about toxicity, which seems like a lot, but you may use it, especially for depending on how big the laceration is, right? So again, these are things that we do on routine basis that especially in an ER sort of setting. So, any questions on that? Okay. All right. So now we're kind of done with the basic gist of things. Again, maybe some calculations on the test that might come up, so be aware of that. And we're going to kind of move into more kind of specific either disease states or patient populations. We'll talk about some kind of common things to run into for some of these patients. So we'll start out with the young ones, start with the neonatal patients. Usually a lot of these kids end up going to the NICU, especially if they're premature or they have any kind of complication. This is where you'll see a lot of these kids at. And so hopefully get some exposure to that on your rotations. But we'll talk about some issues with them. So the first one being neonatal sepsis, right? So one of the big things they always tell you, especially when, at least when I had my first kids, is that especially within the first month or two, if a kid has a fever, what do you got to do? bring them in immediately, right? Because a lot of times these kids that are that young, they won't necessarily manifest, if they were developing meningitis or bacteremia, like they won't necessarily manifest the same way as an older child or an adult patient would. So because of that, if they have any fever, you say you got to bring them in, right? Because again, you want to be on the safe side and would rather treat and monitor that patient rather than just kind of just say, oh, it's probably just a virus and they'll be fine, right? So again, or in some cases, even like the first 90 days, this is where we're going to consider neonatal sepsis, right? So you're going to find that typically the lower the birth weight of the patient, usually the more premature they are, the more likely they are to develop this. Because again, how good is a neonate's immune system? Not great. They don't have a ton of their own antibodies starting to produce yet. It takes time for that kind of build up. Again, it depends, things like whether they're breastfed or not can play a role in their immunity, because they get a lot of antibodies from mom, they're breastfeeding, things like that. But the three main types we're going to find, it can either do to intrauterine exposure. Some of this can be acquired during the delivery process, and also the hospital acquisition. So what kind of happens when they get it actually in the hospital itself. So we'll kind of look at the different ways we can treat that going forward. So some risk factors I mentioned, that they're kind of the earlier, the more premature they are, the more likely they are to develop neonatal sepsis, premature rupture of the membranes, any of these things. Usually the longer the rupture of the membranes has occurred for can be another risk factor. Other thing, especially if mom's had a prior delivery with GBS, which stands for Group B strep, right? It's a big thing we're worried about for a lot these neonatal patients. And you'll find that depending on when the actual fever occurs, it can kind of give you a clue as to what type of bacteria you're going to be dealing with. And that will inform what type of antibiotics you're going to use subsequently, right? So again, you need to kind of take a look at the patient, know what the history is to decide, okay, what is the most likely bug we're dealing with and what antibiotics should I use to treat that, okay? So for instance, if it's a very early onset, which is within that first week of life or so, you're thinking Group B strep, usually for mom in a lot of cases, but also things like E. coli and also like Listeria. Listeria will have a special drug we're going to use specifically just for coverage of that, and usually can manifest as bacteremia. They're a little bit older, say from second week on the rest of that 3 months is where you can see Group B strep come up as well, but you can also see other things like staph, Candida potentially, E. coli are going to pop up here as well. Could be like a focal infection and kind of spreads out to bacteremia, but could or just manifest itself as just bacteremia primarily. So again, notice here a little bit different. There's like Listeria only pops up in that first week, so we're going to see certain coverage for that versus see kind of a more kind of widespread assortment of bugs for the second half there. So usually what we use if we have early onset sepsis, so again, kid comes out, they develop fever early in the first week, we're going to use empiric therapy with ampicillin plus gentamicin. So we're going to basically be using combination therapy in order to kind of eradicate all the likely bugs, right? So again, with ampicillin, what do you think we're covering? You'll get some of that Group B strep, like you get some gram-positive coverage. The other big thing is that ampicillin will cover Listeria. Okay, so Listeria is the other big thing you'll see coverage in ampicillin. Gentamicin is usually used for more of what? So again, before we saw that you can use gentamicin as synergy for like endocarditis to shorten the duration of therapy. This is not the case here. We're actually using gentamicin more for gram-negative coverage, right? So those things like the E. coli and whatnot, you can get coverage for that with gentamicin. That's usually why we're doing that. And so again, note the difference here. Notice, gentamicin only dosed every 24 hours. That makes sense because what's going on with the kidneys in the neonate? Usually underdeveloped, right? So you don't have to give the drug as often because they're going to hold on to it for longer. They're not clearing it as well. These are things to consider. If it was a premature infant, we would give it even less frequently. So a lot of times what we run into, because at Nemours we don't actually birth any children there, but we will get a lot of transfers in from outside hospitals. You have to figure out what they received at the outside hospital to figure out when they should get their next dose of drug when they're here. So again, if they need to get it every 48 hours and they got their first dose at the where they were born, we have to factor that in to make sure they don't get another dose for that 48-hour period. And that can be tough when you have trying to reconcile medical records from different institutions, especially if you don't share things like we don't with a lot of our receiving hospitals. Anyway, so that's something to consider. Usually treatment about 10 days or so in order to get rid of that, unless there's any kind of ongoing issues with the patient. Okay, so some things where you can see factors that are more kind of predictive of kind of bad outcomes in the late onset sepsis. This is where we're going to see things like low birth weight, any kind of neutropenia, seizures. Any of these things are going to be kind of bad news for the patient from an outcome standpoint. Now, notice here our coverage is going to change because we don't have to worry about necessarily things like listeria coverage, but you need to have kind of a wider range of things to cover for, like staph and just a wider net you're going to be casting with this, because it's later onset sepsis, more things the patient could have been exposed to. So what we could do is some coverage for gram-positive things. We can use ampicillin again if we want to, or we can use something like vancomycin. Vancomycin is going to be better for what? Staph, particularly. MRSA is going to be a big thing, right? So all your gram-positive will be covered by Vanco. It's a good option. And then you're going to use plus. You're going to use combination therapy here. Use something like gentamicin, or you can use something like cefotaxime. Cefotaxime being what? Not fourth. Actually, a third generation cephalosporin. And again, we're not using ceftriaxone here. Why? Remember that first month, you don't want to use ceftriaxone on those patients because you worry about that bilirubin displacement. So again, this kind of shows you the guidelines are kind of built already set up to we don't have to think about this stuff, but you'll know why that we don't use ceftriaxone because of that issue there. So cefotaxime or clafuran is a brand name for that. Oftentimes we'll get used. So we either do like amp and clafuran, ampicillin, clafuran, or we'll do like vancomycin and gentamicin. It just depends on kind of patient conditions. Usually don't have to worry about allergies at this point yet, but things like previous history. If other kids in the family had it as well, what were they treated with? Sometimes can inform these sort of things. Anyway, duration of treatment. If it's just a simple bacteremia, 10 days. However, if it's something like meningitis, it's going to be harder to penetrate through the meninges. It's going to be requiring a longer treatment course, and so things like 2 to 3 weeks or so are going to be recommended for treatment there, right? And it kind of makes sense because it's kind of a protected site. A lot of times, a lot of antibiotics do not like to cross over all that too easily unless the meninges are really inflamed. So again, this is why we treat for a little bit longer. So looking at prevention of group B strep sepsis for these patients is important to kind of address the mom. And so usually we're going to screen them between 35 to 37 weeks gestation, and then we'll consider whether or not we need to give intrapartum antibiotics. Okay, so specifically if they're going to be given if they're if you notice there's group B strep in the urine, or if they're identified as a carrier. And so basically, there'll also be another case where you're going to give it if you have kind of an unknown status. So mom kind of shows up, maybe she didn't have great prenatal care, and have these risk factors. So say, prolonged rupture of the membranes or gestation, the premature, temperature is elevated. All these things would kind of inform you, hey, more likely to see group B strep. Let's go ahead and just treat anyway and cover our bases. So usually what we're going to do is give the mom, give penicillin G. So again, what type of drug is that? Easy. The beta-lactamase, right? Or I'm sorry, it's a beta-lactam antibiotic. It's a penicillin, right? That's what I was trying to go for. That'd be kind of easy. You give penicillin G, you can give 5 million units. Basically, IV is a loading dose, and then you can actually give 2.5 million units every 4 hours until delivery. Why do you think we give it so frequently? Remember, it's a time-dependent antibiotic. Remember, their beta-lactams are time-dependent antibiotics. They need to have levels high enough for a long period of time, or as long as you can, in order to kill any of this bacteria. So that's why we give it more frequently. Alternatively, you could use something like ampicillin, or if they have an allergy, is where you can use some alternatives like vancomycin, clindamycin, cefazolin, or Ancef are all very good ones. So again, these are all going to get your gram-positive coverage for that group B strep, right? And then if you have the infant, if they are born and they're kind of ill-appearing, this is where you're going to do kind of a full evaluation. You're going to do things like blood cultures. You're going to do things like lumbar punctures, CBCs and all of that. Typically, if we're not sure, we're going to just go ahead and start with empiric therapy, because then we can scale back if we need to. If it comes back and all the cultures are negative, you can just stop it early. It usually takes 48 hours or so to get those results back. And so you can start with ampicillin and gentamicin just to be on the safe side. And this is going to be that early onset sort of group B sepsis we're worried about. So that's why we start with those two there. That make sense? All right, here's kind of a good kind of flow chart. If you have kind of a healthy appearing infant that is born and you're worried about prevention of group B strep, looking at the gestation, obviously if they're more premature, the younger they are, the more safe you're going to play it, the more likely you are to treat with antibiotics. So for instance, if they did not get intrapartum antibiotics, say less than 4 hours prior to delivery, you can start off with kind of the full shebang. We're doing CBC with differential, blood cultures, and antibiotics. However, if you had someone who's a little bit older when they were born, say greater than 35 weeks, and they did get intrapartum antibiotics, maybe just do evaluation, maybe observe for 48 hours or so. So again, kind of the worse off they are, the more premature they are, the more likely they are to do kind of more invasive monitoring and start off with those empiric antibiotics. So just know kind of what antibiotics to start with. If it's kind of late versus early onset sepsis, those kind of questions I might ask on the test. So I don't hear a lot of typing, and then when I say something about the test, and all of a sudden you're typing. The other thing you have to consider is things like neonatal herpes. So you can see that most of this is going to be caused by simplex 2. However, some of it can be by simplex 1 as well. And this is usually where the kids are going to pick it up kind of through the birth canal. It manifests in lots of different ways. Certainly, you can see some nasty CNS manifestations. It may present as seizures in some cases. That's why you see a seizure in an infant. Like you kind of have to do the kind of the full diagnostic workup, because it could be something like a febrile seizure, but you have to consider all these other kind of nasty things that it could be, like herpes. So, anyone know the drug we use for herpes? Yeah, so we're going to use acyclovir for that. It's going to be our main drug of choice for those patients. So. Basically, I'm not going to get too much into kind of the disease manifestations. Just know that it has kind of a wide range of things it can show up as. But the big thing is going to be acyclovir. Usually, you're going to do this Q8-hour dosing. We like to start with IV at least first, in order, because again, oral is not going to be a good option for neonate in this time frame. But IV is going to be a good way to get that drug into the patient and treat in the virus that's around there. Typically, if it's a kind of more diffuse disease, or if it's like CNS affecting. And then we would treat for a longer period of time, usually 3 weeks for those patients. Okay. So how much time do I have left? 5 minutes? Yeah, I have 4 minutes. I can cover something else. Okay, the other thing we worry about, especially with premature neonates coming out, is we worry about respiratory distress syndrome. So what kind of helps our lungs stay nice and inflated and surfactant, right? So again, the more premature you are, the less likely you are to have started surfactant production. And so this is a big thing we worry about. We see this a lot when we have our transport team that transports a lot of these kids that were born outside hospitals. They have to get transported to us. We will send them a lot of times with exogenous surfactant we can actually give the patients. We'll talk about that in a second. But basically, if you don't have that surfactant, it can result in atelectasis, improper ventilation, and can lead to lung injury kind of in the long term. So usually surfactant production begins around 32 weeks gestational age and matures around 36. So if you're born before that, you don't really have a whole lot of surfactant production going on. We will have to give it to you. There's some things we can actually do for the mom to increase production, and so we can give antenatal steroids, something like betamethasone or dexamethasone. That could be one way we can actually try to stimulate production of surfactant early. Other things like maternal hypertension actually increases as well, which I thought was kind of interesting, and prolonged rupture of the membranes tend to increase surfactant production. But if you don't have that, we can actually replace it by giving exogenous surfactant ourselves. And so again, these are things that put you at risk factors for that, which again, I won't ask too many questions on, or I really wouldn't ask questions on, but we'll have our surfactant here. And so we will sometimes give this prophylaxis, say like up to 30 weeks gestational age. If they're born before that, we'll actually give them surfactant to try to help supplement whatever they're not producing themselves yet. And so we'll give this at birth. Does anyone know how we give surfactant? Ever seen it? Which route we actually give it? It's kind of interesting. We actually give it via the intratracheal tube. So if we were to intubate these patients, you can give it via the intratracheal tube. Because again, where does the surfactant need to go? To the lungs. So we can actually instill it directly into the lungs. And so it's kind of interesting. And again, we've seen it does help hasten recovery for these patients. It helps to prevent a lot of these kind of secondary conditions happening here. But we can give things like Survanta or Baractant, or have Curasurf, called Poractant, and basically you would instill it through the endotracheal tube. So if you ever see ET, that's what that's referring to, not the extraterrestrial, but give the ET tube. And notice here, same kind of dosing as you see for other things, like 2 mLs per kilogram. You dose that, and you actually have to kind of rotate the patient to make sure you're kind of getting a good coating on the lungs. You may kind of like put them in one position, instill it, part of the drug in there, and then kind of shift them over, and to try to get another portion of the lungs there. So that's one way we can actually try to get better coating and kind of better action of the surfactant there. Right, so I mentioned you're kind of doing it in divided doses, so you'll do kind of 2 to 4 aliquots. Anyone familiar with that term, aliquots? This is kind of a smaller portion of a larger amount. So if I took, say I had a 30 ml, say I had 1 ounce of fluids, and I took a 5 ml portion of that out, that's an aliquot, right? So again, another little nerdy pharmacy term you can wow your friends with, right? Basically, you can put the infant in different positions and instilling those aliquots into there, and hopefully getting good coating. And actually, they have specific recommendations on like ventilator settings to go along with that. So a lot of times our respiratory friends are kind of helping with this. And again, we do not want to shake the surfactant, because again, one thing you'll note with protein-based products, you never want to shake. Has anyone ever shaken a protein-based kind of solution? I don't know what happens to it. It's very foamy, right? Everyone really, you see like proteinuria, like it's very foamy kind of urine. Same thing happens to these drugs as well. So again, this goes for any of the monoclonal antibodies we've talked about. It goes for anything protein-based. You do not want to shake it because it'll get very foamy and all that drug will denature as it comes out of solution. So you gotta be very careful with these products. Anyway. Okay, so I'm gonna go ahead and cut it there. Any questions for you guys before I go? All right, I'll get working on your prescriptions, try to get those graded. Again, give me some grace there. There are quite a few of you and quite a few of those. Again, 3 might not have been the best idea, but it will enrich your careers in the future, so it's worth it, right?